All right, so the next cardiovascular lecture happens to start with us talking about the heart cycle. So the heart cycle, we're basically going to be talking about how the heart works as a dual pump with the atria and the ventricles alternately contracting. And so when a heart chamber is contracted, it is in systole, and it was relaxing, it's in diastole. So there's going to be the words that we use a lot throughout all of this. And also the cardiac cycle includes all the events of just one heartbeat. So basically what's going on is when the two atria are in systole, so when they're contracting, pumping blood into the ventricles, the two ventricles are in diastole. So atria are in systole, ventricles are in diastole. So then that's going to switch because it's that dual pump. So when the two ventricles are in systole, the atria are going to be in diastole, filling up with blood. So blood flows from areas of high pressure to areas of low pressure. So when the two atria are in systole, the pressure is high, they're contracting, which pumps blood into the ventricles. The ventricles are going to be in diastole with low pressure. So it's going to go from the atria to the ventricle. When the two ventricles are in systole, the pressure is high in the ventricles, which pumps blood into the arteries, and the pressure is low in the atria because they are in diastole, relaxed. But as filling occurs, arterial pressure is going to increase. So it's going to be a constant cycle going on. Two things we also have to talk about, the AV nodes and the SL nodes. So you have the atrioventricular and the semilunar nodes. So when the two atria are in systole, once again contracting, and the pressure is high, the AV valves are going to open to allow blood to pass into the ventricles, the atrioventricular valves. Then the SL valves, or the semilunar ones, are closed at that time because you don't want the blood just going straight through. So then when the two ventricles enter systole, that's when you have the semilunar valves open and the AV valves are closed. So blood pressure is measured with that cuff, and it's measuring the force of blood in the vessels during systole, so that's going to be the bigger of the numbers, and then as the blood pressure cuff releases, it's measuring the diastole, and that's the smaller number as it relaxes, as the ventricles relax. So the blood pressure cuff is also called a sphygmometer. And the average blood pressure of a person is going to be 120/80. Now there are people who are slightly higher than that, slightly lower than that, and those are normal ranges. It's just the average is 120/80. If you have a higher systolic blood pressure, that's when doctors are usually looking at should you be on high blood pressure medication because it's considered dangerous. So there are four things that can affect blood pressure, and they are cardiac output, blood volume, blood viscosity, and peripheral resistance. Those are the four things that affect your blood pressure. And with that, we'll move on to some heart sounds. As you know, hearts kind of make that lub-dub sound if you ever have listened to the heartbeat of someone. The lub is the closing of the AV valves, and the dub is the closing of the SL valves, or semilunar valves. So if the closing of the valve cusps is incomplete, some blood goes back, and that's when you get the heart murmur. So when you're actually listening to that with the stethoscope, you can hear swooshing sound rather than a lub-dub. That is typical of a heartbeat. So murmurs are kind of swishy sounds. So lub-dub sound is the heart actually opening and closing those valves. And the instrument that we use to measure it is that stethoscope. And the normal heart rate for an adult is 60 to 100 beats per minute. And we also measure those. You can do different pulses, wrists, carotid, brachial. If it's a child, that's where you want to check their pulse. You also have different nodes, but we're not going to get into that this year because we will run out of time. All right, so we're going to get right into ECGs. So ECGs is just an electrocardiogram, and it is just a recording of the electrical events during the cardiac cycle, or the one beat of the heart. So it is used to determine if the conduction pathway is normal, whether the heart is enlarged, or whether or not certain regions are damaged. Just some things to remember is depolarization precedes contraction, repolarization precedes relaxation. So there are 3 waves in a heartbeat. So those are those little machines that you see in the hospital. The first wave is the P wave. It's a small upward wave, and you can see it in your guys' notes. That small upward wave, that is the depolarization of the atria, so atrial contraction, which is systole. So 0.1 second after that P wave begins, the atria contract. The other part of the wave you have is the QRS complex, and that is the depolarization of the ventricles. So ventricle contraction, the ventricles are in systole. So this begins as a downward deflection, so you have that little P wave and then it begins a downward one, and continues as large upright triangular wave and ends as a downward wave. So when you're looking at your picture right here, you have the you can see the different waves. That tall wave is the middle of it. So it starts with the downward one, has that huge triangle, and then ends on that downward wave. For the QRS complex, and shortly after that QRS wave begins, the ventricles start to contract. And then you have your T wave, which was that dome-shaped one at the end of the picture I just showed you. And it represents ventricle repolarization. So it occurs just before the ventricles start to relax, which would be diastole. And the shape indicates that it is a slow process. All right. If you look at your notes when you're analyzing an ECG, you're looking to see if there's tachycardia, which means a fast heart rate, bradycardia, which is a slow heart rate, and arrhythmia, which is just an irregular heart rate. So next we're talking about some cardiac conduction system, or the nodes that are composed of cardiac tissue, which conducts those electrical impulses. The first one we're going to talk about is the senatorial node, and it is located in the upper right, or the right uppermost atrial wall. So and it is called the pacemaker. So it is a self-exciting tissue, so it generates rhythmic impulses which spread throughout the myocardium. When the SA node fires, which is short for senatorial node, the impulse travels from the fibers of the atrial syncytium via gap junctions and intercalated discs, which will eventually result in atrial contraction. So it all is starting from the senatorial node, the SA node, the pacemaker. Then you have your junctional fibers, which are carrying the impulses into the AV node, your atrioventricular node, which is located in the interarterial septum, and it serves as a delay signal that allows ventricular filling. And then you have your AV bundle, atrioventricular bundle. So only electrical connection between the atria and the ventricles, so that's this bundle. And it's in the superior, so the upper interventricular septum. So it's a right and left branch transmits impulses to the walls of the ventricles. And then lastly, you have the Purkinje fibers, which branch throughout the walls of the ventricles. They're very large in diameter, and they're located within the papillary muscles of the ventricles. And they carry the impulse rapidly stimulating contraction. So those are a brief description of the nodes, or the cardiac conduction system. Regulation of the cardiac cycle. This is controlled by your autonomic nervous system, which is, specifically the cardiac center of the medulla oblongata. And that is going to increase or decrease depending on changes of state. So it's all about maintaining homeostasis. Even if other parts of the brain are damaged, because it's controlled within that medulla oblongata, you're still going to get a heartbeat. So the cardiovascular center is in that medulla of the brainstem, and it has parasympathetic, which is normal, and that's going to be decreasing the cardio inhibitor reflex center. And then you have the sympathetic, which means you're stressed. It's a stress response, and that's going to be cardio-acceleratory, so it's going to increase your heart rate. Chemicals that do this, we talked about epinephrine is going to increase your heart rate, calcium, and if you have a decrease in potassium and sodium ions, your heart rate will go up as well. Your heart rate also decreases with age, so as you get older, your heart rate declines. You also have, depending on your temperature, how warm you are is going to affect your heart rate, emotion does, as well as disease. So those are all things that will affect the regulation of your heart rate. The last, or I guess there's two more sections here, blood vessels. So in your blood vessels you have things called arteries, and these are the strongest elastic vessels which carry the blood moving away from the heart. So if there's an artery, it's taking blood away from the heart. And it goes arteries, arterioles, capillaries. Next you have veins, and they are thinner and less muscular, but they carry the blood to the heart. So veins carry blood to the heart. And they go veins, venules, capillaries. So capillaries penetrate nearly all tissues. They're just walls, and they're composed of simple squamous, one layer of squamous cells that's very thin, but they have a very important function. They are the cells that are involved, or that allow the exchange of materials, that exchange of carbon dioxide and oxygen. So looking at capillaries, smallest, thinnest blood vessels. Yes, okay, we covered everything there. Let's go ahead and go into the control of blood flow. So you have precapillary sphincters, and sphincters is just fun to say, but they are circular valve-like muscle at the atrial capillary junction, and so they are going to be on vasoconstriction, which is the narrowing of blood vessels, and vasodilation, which is going to be the expanding of blood vessels. So those are very important words to understand when doctors are talking to you. Understanding vasoconstriction, they're constricting, vasodilation, expanding. So blood flow through veins is not very efficient. but there are factors that affect the blood flow through the veins. It's the contraction of the diaphragm, the pumping action of skeletal muscles, and valves in the veins. So that's the part that plays a role in getting the blood back to the heart. So once again, we already covered factors affecting blood pressure, but blood pressure is controlled by a lot of different factors. So we talked about cardiac output as being one of them. It's the volume of blood pumped by each ventricle each minute. Not something you really calculate out in the field as an EMT, but something you need to know how to calculate. The volume of blood circulating through the systemic or pulmonary circuit a minute is that cardiac output. Blood volume is normally fairly consistent. And then you have blood viscosity, which is just how thick your blood is running. So remember, like corn syrup is very viscous, water not so much. And then peripheral resistance is the resistance to the opposition, the resistance to blood flow, primarily due to friction. So this has to do with the friction of the blood on the walls of your blood vessels. Your major blood vessels are going to be your aorta. So you have your ascending aorta, the aortic arch that is fairly familiar probably. You have the pulmonary trunk, which splits into left and right. The pulmonary veins, which return blood from the lungs to the heart. And the superior and inferior vena cava, so superior head and upper limbs, inferior trunk and lower limbs, bringing blood to the right atrium. So that is your basic aortic information. There is a lot more. I'm not going to go into it too much. So SADS and SIDS, so sudden adult death or sudden infant death, is just when the heart stops. So a lot of the times, especially like as an EMT, when we're doing like cardiac patients, we'll have an AED, which is an automated defibrillator. So it's going to deliver a shock to that heart if it is in, if it has a arrhythmia. So it has a defibrillation. It sends some sort of erratic heartbeat. It will shock the person. If it doesn't sense a heartbeat, it won't. While you're doing the AED, you also are going to have to administer CPR. A lot of you are probably certified in it for various reasons, but CPR is 30 chest compressions to rescue breaths. You can do hands-only CPR if you don't have something to protect you from the patient. Typically, as an EMT, we use a big valve mask because those are much better than the little mouth mask things, because the patients who you have to perform CPR on often vomit, and you want your face as far away from that as possible. So CPR is performed with patients that are pulseless and apneic, so pulseless and not breathing, trying to get that heart going again with the chest compressions and some airflow with the 2 breaths. And that is all for the second cardiovascular video.